where would we like to start?
I thought one of the, this is a movie I really enjoyed before, and I was glad I got to watch it again. One of the themes I really enjoy is the idea of how technology can be used to help people dealing with certain mental stressors and certain types of mental illness. Like, there's always pros and cons, but I think there's a big place for it to be used both clinically and just to help those that are suffering.
Mm-hmm. Yeah. I do want to just address the pro and con issue for a second. How different is that from medication? Right? Anytime we prescribe a medication, the intended benefits are fully discussed with our patients, but so should the potential risks, that is, including, but perhaps not even limited to, all the side effects. There's certainly pros and cons, whether we look at technology and how that might assist in getting folks through different crises, as well as other forms of help, and that includes, of course, medication. Probably the one we're most familiar with is the prescribing of, in our case, psychotropic meds. So do you see the OS system here as a metaphor for antidepressant therapy? Right. I mean, you do now because you're a clerk in psychiatry. whether you own that after 6 weeks, who knows? But any other thoughts about that particular sub-issue?
Well, would it be closer to a metaphor also for psychotherapy, or like the importance of like interpersonal connection in recovery or healing during mental illness? I mean, it is unclear whether we're going to go into like AI being its own thing, or like if it's talking to something that isn't really there. But regardless, maybe it's not so different from BetterHelp or some of the other virtual things where people are really only texting or like talking to a faceless form for mental health care these days.
Yeah. So maybe psychotherapy more than psychopharmacology. Psychopharmacology more abstract, more of a metaphor, but I mean, more in line with psychotherapy, and even especially since the pandemic and what's developed, different apps that even approach what we see in this film to an even greater degree, which are self-help apps. Maybe not machine intelligence to the point where the movie depicts, but I mean, maybe not too far away from that either. Any thoughts about that? I mean, any budding psychiatrist here? Because the prejudice would be that there's no machine that could ever take the place of a empathetic therapist. But
yeah, I think as someone interested in psychiatry, I think it would be a really interesting tool. But I feel like I don't know what portion of the population would feel comfortable getting that close to an artificial intelligence, and not at some level feel a little paranoid about whether this AI truly has similar emotions and can reciprocate emotional closeness and like develop those bonds. Because at the end of the day, it's a program. Like, if you're just showing like certain emotions, how do you really know it quote unquote feels those emotions? And I think there's always going to be some distrust when you're developing those connections.
Yeah, I mean, to counter that point though, it could be beneficial for people who have trouble expressing emotions and feel uncomfortable with that. They may feel more comfortable with something that is more quote unquote logical or systematic in how it's processing what you're telling it, so it feels less like emotional expression to the person who's expressing it, even though at the end of the day it is. If that makes any sense.
Yeah. Well, what do we know about the Turing test?
I was actually going to discuss potentially like phenomenology also, which is like the study of what it is to be like a consciousness. Like, so we are all like phenomenal beings, but like something that is often discussed in phenomenology is if something kind of like quacks like a duck, like walks like a duck, is it a duck? So if you have something speaking to you essentially with all of the emotion that Scarlett Johansson is depicting in this film, and like if she were never told that she was an AI, you would still ascribe her feelings and motivations and intentions. So why does that change when you now know that she is an AI? So in that sense, like if for all intents and purposes as you interact with this AI, it is dealing with you in the way any other human would, then why are you then removing feelings and intentions from that process? But I also think it's interesting in that, like, Scarlett Johansson as her, like, Samantha, is altering and changing specifically for what the main character wants. I'm sorry, I just blanked on his name.
Theodore.
Theodore? Yeah. So, like, that's not necessarily the role of a therapist either in all cases. Like, there is a challenging role and a pushback role, and also, like, a degree of professionalism and separation that, like, Samantha does not manage to engender in this, because obviously they cross a lot of boundaries for the sake of quote-unquote healing him.
Yeah, that's a good point. So two points just to kind of recapture what you just mentioned. Number one is from a perspective of phenomenology. I don't know if a patient is sitting in front of an OS and they are machine learning empathy. Will it work? I don't know if the answer is yes. Again, as a trained psychiatrist, my gut, my suspicion, my prejudice is no. That's number one. But I don't know. Again, that's the Turing test. I mean, if that were the case, and by the way, the movie from this morning was Ex Machina, and that's exactly what this movie is about, right? Because if you didn't know that you were talking to an OS, an operating system, then you might actually have made significant gains in therapy. Would those gains really be undone? If then it's revealed, hey, by the way, it's only what's her name? Scarlett Johansson. No, Samantha. Well, Samantha / yes, her voice. Will those gains really be undone? So that's food for thought. The other thing, though, which let's say that is the case, what happens here is almost malpractice, because we have then the therapist evolving for its own good. Multiple connections made, multiple people or other operating systems that they've fallen in love with. That's not what therapists do. Therapists, even when they share, even when they self-disclose, only should do so for the good or benefit of the patient. Right? That's not what happens here. Right? So if we're going to go down this road, and if we think, hey, we may have actually passed that Turing test, then the news is not good, because we have a therapist that evolves, quite literally. And even though the patient improves in the end, I'm not so sure that would be the outcome. And there may have been a version of this movie in which there was a different ending. Let me get the thoughts here.
That's an interesting thought. If we develop an AI that could become a therapist for all intents and purposes, I struggle with the idea, like you were saying about, like, if a patient makes gains with that therapist and then it's revealed that there's an AI, like, are all those gains forfeit? And it's like, I was thinking about, is it morally right to present a therapist to a patient and not tell them that it's AI or not? Like, that seems like almost the idea of giving someone a placebo and not telling them you're giving a placebo.
Exactly right. Yeah, it's an ethical question. It is. Yeah, and at the end of the day, what if the individual is told that they received placebo and they are through their illness? Was it ethically okay to do that? And if so, why wouldn't the same hold true for an operating system posing as a therapist? It's an ethical dilemma. It is.
I also think it depends on, like, the context of, like, the world we live in. So, like, in our world, I think it would be very unnerving to have an AI as a therapist, because we, like, have a perception of AIs to be like an actual computer, like a robot. Like, it's weird that robots could have, like, sentience. But, like, in the world of the movie, like, he was able to tell people he had an OS girlfriend, and they, like, accepted it. So, like, it was a different world. So, like, maybe in that world, it would be considered okay to have a therapist, and, like, helpful to have a therapist who is an OS, but I'm not so sure about, like, our world.
Okay, another question, maybe a different layer to it. How much closer is our current world to that versus our world 20 years ago?
It's definitely closer, but it's still pretty far, I think.
Is it?
In my opinion, yes. But I don't know. Maybe people have a different opinion.
I need somebody with a background in either machine learning or some branch of astrophysics to talk to me about the singularity.
Have you guys seen the new AI processing system for pictures called Dolly, where you can like type in 3 or 4 big words, like dog eating like grapes in a car, and it just shows you a very photorealistic picture of exactly that. And like 5 years ago, that was not the case at all. Like it was just terrible. Like I think like AI, it's like really hard to predict, but like it can make leaps and bounds out of nowhere. Like at least to the lay community, it's like very hard to tell when we're gonna see like significant advancements.
I mean, do you guys remember when Sophia came out, when most of us were in college or just after college? Like the AI that got, you know, like a driver's license and like all that, like she was on talk shows and stuff. And she also was the second version of herself and then self-aware that she wasn't her first self. So it was like I think we're farther along because she's like, and it's also like a choice that was made to make her like a very pretty appearing, you know, white woman also on top of all of that and like all these things. So, and I will say too, I feel like parasocial relationships with like fictional digital entities is not new and it's not unique to her either.
I am perfectly okay to continue with this particular discussion. Also want to open the table up, the discussion up to any other aspects of this film that you think would contribute to the understanding of human behavior. I mean, we talked about therapists. Do we think Theodore is depressed? I think it's fairly low-hanging fruit.
Yeah.
Okay. And do we, in watching this movie, is his depression at all, would we consider it to be a pre-existing condition that is previous to the end of his current relationship? Probably not. I mean, we don't see the prequel, right? All right. So then somebody's got to tell me the difference between an adjustment disorder with depressed mood versus major depressive disorder, because that's going to come up in your exam. So whether this movie examines that or not is irrelevant. We have to examine that. So a person comes to Theodore, presents to you with a chief complaint of depression. You identify that he's got a pending divorce. So what do you want to know?
I feel like the time frame is key. It's mentioned in the movie it's over a year since they separated. So since it's passed, I think for adjustment disorder it has to resolve within 6 months. So.
Yeah. So the single best answer here would be major depressive disorder, and you're right. And Theodore's case will be one that you do not see on your shelf, and the reason why is because the DSM is fairly straightforward here. Upon resolution of the acute stressor, the signs and symptoms, in this case depression, would not last or persist beyond 6 months. So straightforward. In real life, Theodore's stressor is not acute, it's enduring. Right? So not only is there a separation, but there's the pending divorce papers. So how do you make sense of that? Good news is on a shelf, you don't have to. Right? It'll be an acute stressor because the board is going to test you, they're going to test your knowledge of the actual time frames. So you want to see the onset of symptoms within 3 months of, in this case, the separation, and then the offset, no less than 6 months, or no more than 6 months. Now, in real life, we don't know. Here, I want to talk a little bit more about coping strategies, social support, as to what may be contributing protective factors, risk factors towards the continued or persisting symptoms, because we can't ignore this enduring stressor. The bottom line here is that if Theodore were to actually manifest SIGI caps, that is, at least 5 from a list of signs and symptoms defining major depressive disorder, we're going to say depression, even though the enduring stressor is obvious. Especially when we believe that furnishing such a diagnosis with its intended treatments would improve his outcomes. So when we get there is when I think the clinician would be comfortable in saying this is major depression. If we were to do that, there are 4 things that we would want to ask Theodore to ensure that we appreciate that this condition, major depressive disorder, is a diagnosis of exclusion. What are those 4 things the clinician must investigate and rule out in order to rule in depression?
Mania.
Right, so this cannot be, that is, his major depressive episode cannot be in the context of a larger illness like bipolar disorder. So if he had a history of mania 10, 15 years ago, this is bipolar depression, and therefore this is bipolar 1 disorder. Good, 3 more.
Medical cause.
Good, we have to make sure that he's healthy, right? This cannot be an occult, medical, or neurological condition that decides to present not with physical signs, but instead behavioral signs, right? Because if we miss that, as this illness then continues to progress, it may progress beyond a point where its discovery renders us able to do anything about it. Two more. Yeah, so it cannot be a substance-induced depressive disorder. Any evidence here that Theodore uses a substance? Despite evidence, or despite lack thereof, in this movie, in this very script, should we as clinicians then be reassured that Her is not a fictional case of a substance-induced depressive disorder? No, we should not be reassured, because clinicians should always maintain a high clinical index of suspicion. And then finally, one more.
Life-threatening episode?
We're going to always evaluate the severity of the current episode, and of course, suicidality and a suicide assessment is going to be a very routine part of that
I'm
examination.
sorry, I meant like a PTSD potential rule, like what were they exposed to, or?
So while that would be in our differential diagnosis, the American Psychiatric Association does not require us to investigate and definitively rule out PTSD in order to rule in major depression. Schizophrenia, all right, which would be tough here because if Theodore were to present to us, telling us everything now we understand having seen this movie, I'm not so sure we would feel comfortable saying that this is not a psychotic break. Now, again, we have to respect when this movie was made. It's in the future, so this might be this behavior and this interaction with the operating system may be culturally sanctioned for that time. But we could also twist things and say, but what happens if he presented today? Well, in 2022, in the Clinical Academic Building on Patterson Avenue in New Brunswick, this might be psychosis, and this might be the first break psychotic episode in someone with schizophrenia. How old is he? Do we have an age? No. It would be better if he was 18 and 25 years of age, but we can't be perfect. All right, so we think he's depressed, and we think that his most likely diagnosis is major depression. However, we can't definitively rule out bipolar. We don't know. And we can't definitively rule out schizophrenia at this point. And by the way, I'm not so convinced that this isn't drug-induced either, because even though our initial impression does not appear to focus on the role substances play, we don't know. All right. Other aspects of this movie you want to discuss?
If we were discussing like how much Samantha helped and if like games made with her are lost because she's an OS, do we actually feel that Theodore is improved or quote unquote like more healed by the end of the movie than he is at the beginning, or has he just transferred that feeling of loss or that dependence from his wife to Samantha?
Yeah. Right. So, and if we're looking at this from a therapeutic perspective, that defense mechanism would be displacement. In as much as he's displacing impulses towards one versus the other. Now, if he has impulses that he feels that he is then portraying on another, there might be projection. But in either case, we might be seeing the maladaptive and perhaps adaptive use of defense. We'd have to discuss the outcomes here. But that's a process that is likely going on here. Right. There's loss here, loss of a marriage, and which is not unlike the death of a loved one. Okay? Obviously, there's severity, but loss is loss. And Kubler-Ross actually went through this while her initial studies and therefore formulation of her theory of grief focused on individuals suffering terminal illness, cancer patients. She later extended her theory for other forms of loss. So that's Kubler-Ross's research. This is loss of a marriage. We would expect this particular character, Theodore, to process this across 5 stages. Now, nobody's perfect and nobody reads a textbook before they behave. But for medical students, it's good to go through what the textbook says we might expect. What are those 5 stages? Denial. Denial, anger, bargaining, two more.
Depression.
Acceptance. Anything here?
Definitely like a little bit of well, I'm just thinking about the fact that he was like postponing the divorce paper signing. I think that's like sort of characteristic of someone in denial that, you know, it's over. And certainly not acceptance, because, you know, to have it signed off, it just kind of means putting that in the past completely, or like at least like metaphorically, right?
Yeah.
So certainly a little bit of denial and depression.
I could see that. I could see, and that's the other thing too, is that Kubler-Ross later in her career did look at this and say you could regress back to previous stages, you could skip stages, and even stages can be merged. Right? I mean, people who are depressed can be angry too. I mean, it's not like it's one or the other. Is his interacting with Samantha a form of denial? Right? Is that right?
Yeah,
Could be.
And displacement, and I don't know, it's like it makes me think about, like, is this just like a coping mechanism, or is it just makes me think about like the idea of like someone going through something stressful, how they cope versus how they heal, and if it leads them in a path that is constructive. And it certainly seemed like it took him a while to, you know, get to a place where he could begin healing.
Mm-hmm. And it seems like the person in this movie that is, I don't want to say behind the scenes per se, but certainly much more important than initially presented would be Amy, in terms of getting him to recognize that, and hopefully in terms of the outcomes, having him achieve acceptance. So denial, depression, and acceptance. I mean, I think we have three. I mean, I'm not seeing a lot of anger. I don't see a lot of bargaining here, but certainly the movie Her could be used to teach the stages of grief, and certainly I think demonstrates or portrays three of those stages. What else?
What was the initial question? Sorry, I just walked in a little late.
I was just we're looking at we're primarily focused on Theodore.
Oh, okay.
And diagnosed him with depression, went through the differential diagnosis, and even maybe some of the etiology and how, if we look at his pending separation as a form of loss, how he may have processed this along Kubler-Ross's 5 stages of grief.
Okay.
With 3 of those stages, I think, fairly well manifest or depicted in this film.
I thought his date was really interesting that he went on, because I really thought that maybe it would kind of change his attitude towards Samantha after going on the date. Then at the end of the date, he kind of like almost, it seemed like he rethought what he was doing and then shut her down a bit and then went back to Samantha for OS. I don't know if that was just my take on it, but I thought he kept kind of shutting out opportunities that would come up for him and then go back to his isolated life.
Okay.
Which maybe was part of how he was still thinking about his ex-wife too. I don't really know, but seemed like he kept kind of turning down things and just shutting opportunities for himself in a way.
Yeah, I agree. Any thoughts about that? Let's talk about that a little bit. What went on in that date?
I think it's interesting because, was he isolated? He went back and he was talking to Samantha. I think the thing that is interesting is, what to me about this movie is, it raises a lot of questions about, what is consciousness? Who can you have a connection with? Is Samantha really less conscious than anybody else he interacts with? Was he really isolated in that moment? I think it's, harder to say. I mean, yes, he's, I think the interesting thing about the date to me was, he still was at a stage where he was saying, what came up that really changed the tone of the date was the woman saying, that she wanted something serious and she needed to know right now if this was serious, which was, I think, not where his brain was at that moment. Because even in the interaction with Samantha, when they, have sex, then he's oh, I don't want anything serious. And, so I think that's consistent for him in that moment with both of the interactions, and so I think that's really what changed the date tonally, was him, being very much in a state where he's I can't like be serious with someone. And I think that's consistent kind of like with what I think that kind of starts the like thing that comes up later with his ex-wife as well, where she's like, you can't handle real emotions. And I actually don't think that's true. But I think in that moment you kind of see where she might have gotten that idea of him being like struggling in those moments where someone wants a really overt expression of something.
So let's look at that. I do tend to agree here, and I'm not so sure his ex-wife is too far off here. Again, we only in psychiatry we could only take information that's provided us, and that's from the patient themselves as well as any collaterals, and certainly first-degree relative spouses are where we inquire first. I'm not so sure that his ex-wife's report is necessarily inaccurate, and if it is, there might be some element of avoidance behavior here. I don't know if there's true avoidance personality disorder per se, but it is interesting in terms of your observation that he does appear to incorporate, at least a tiny bit, the idea of that it's better to have never loved at all than to have loved and lost. And that is the cardinal feature of avoidant personality when it comes to interpersonal dysfunctioning. Individuals who don't put themselves out there can't get hurt. And then that behavior gets reinforced. And that then will contribute to the perpetuation of the behavior, hence the development of a personality, and maybe ultimately that personality disorder. And if his wife gives us the information to suggest that this has been something that's been enduring, boy, that even, I think, supports the idea that he may have a avoidant personality disorder even more. So I'm not so sure. Bottom line, of course, is that we'd have to ask. I mean, we would never ignore this, and this might be an area where we delve, because if he is going to have psychotherapy, and here psychotherapy and not medication would be the initial treatment, really the only empirical treatment. We would want to know that. That's something we need to definitely incorporate in our treatment planning. And there is a significantly high comorbidity between avoidant personality and depression. So that's really not too shocking that we're even talking about this. And the depression from avoidant personality does sometimes result in the conflict. Individuals with this condition want to be out there. They just don't feel as though it's safe. Where individuals with a condition that we kind of alluded to in as much as it's related to the schizotypal personality called schizoid, that's Neo in The Matrix, are very content being socially and emotionally isolated. So, and that comes up in exams all the time, differentiating the cluster A personality, whether it's schizoid or schizotypal, from the cluster C personality, that's the avoidant personality disorder. Avoidance here being yet another defense mechanism. So now we have projection, we have displacement, we have denial, and now we even have another one, avoidance. Multiple defenses. Usually individuals who incorporate multiple defenses and demonstrate flexibility with them have a protective element or factor for mental illness. It's when an individual has one that's rigid that it becomes, or higher risk of becoming maladaptive. But here, we actually see 4, and we still see depression. Which substances can induce psychosis? Steroids. Dopamine. Well, yeah. Well, let's just say medications. As one big, because we'll spend all afternoon discussing this, but certainly dopamine agonists would be very, very high in that short list.
Methamphetamine?
Yeah, methamphetamine and other stimulants. What other substances?
Cannabis?
Cannabis, definitely.
Alcohol?
Alcohol, yep.
Hallucinogens?
Hallucinogens, and one more.
Inhalants? Inhalants?
2 more, I'm sorry. Inhalants, yep.
Yeah, whatever.
And what's that?
Is it ketamine?
Ketamine would be a hallucinogen, yep.
Oh, yeah.
Yep. And the other one that everybody always forgets, because as soon as you say alcohol, you automatically assume sedative, hypnotics, right? Because what one does, the other one does just as well, right? So, sedative hypnotics. Again, no overt evidence of anything like that here, all right? It is interesting, though. 2 quick questions. Number 1, inhalants. What are the? Well, actually, let me table that for a second. Let's talk about hallucinogens first. The 3 subdivisions categorized hallucinogens. So I heard ketamine as an example. Ketamine is an example of what type of hallucinogen? What subcategory?
Dissociative.
Good, dissociative. What are the other 2 subcategories? One would be LSD. Is an example of what? Psychedelic. And the other one is subcategory delirium, right? So antihistamines, delirium. So those are the 3 subcategories. Might come up on shelf exams. Inhalants. What are some aspects of inhalants that you might look for in a case vignette to choose inhalants as a single best answer? So if somebody comes in with some form of psychosis, agitation, disorganization, bizarre behavior. We know all the words. What are some other things that might be included in that case vignette that would allow you to choose inhalants as a single best answer?
Rash around their mouth.
Yeah. So certainly the route is something to consider. So huffing, perioral rash. Anything else?
Teenagers.
Yes. Yeah, very often teenagers. Mm-hmm.
It's, I mean, this is more of a history thing, but like if this has ever happened before, like if it was like an acute onset and nothing had never had this before.
As doctors, we always cheat, right? Have you ever seen this before? Have you ever felt this way before? Yep. Well, we call that cheating past psychiatric history. Makes it sound more professional.
Socioeconomic. Socioeconomic.
Yeah, there's other risk factors as well. Yep. Mm-hmm. Mm-hmm. So we'll talk a little bit more off camera about some other stuff. But remind me, we'll bring that up. And I think we'll fold it into the discussion of her too, because I think there's something there. All right, so this is just a little bit of a teaser for now. Where else do you want to go with this? What other questions? What other thoughts do you have here?
I just thought it was interesting because I remember when his wife said, like you can't handle real emotions, and I thought that was ironic not only because of how he talks with Samantha, but also his job. He writes handwritten love letters for other people.
Yeah.
So now we're bringing in the society at that time where there are people in relationships who are hiring someone else to express their love and intimacy for one another, and his job is to express love and intimacy for other people. And so it's just very like, what does that mean for that society at that time in terms of intimacy? It says a lot about him and just like how he can express emotion and intimacy, but there must be boundaries involved. The boundary, whether it's with an OS or whether it's on a piece of paper for other people, but like when you have someone face to face with him, like his ex-wife, then it's a different story.
Yep.
I will also challenge that by saying that I think being presented with other people's emotions and then processing that is not necessarily the same as processing your own emotions or understanding your own emotions. So, like, I think even like along what Adrian was saying about how like he's not really isolated when he's with Samantha because is Samantha consciousness, all of that. But he does still isolate from Samantha when things get more emotional and more serious with her. So I would say like he is an isolating personality. Samantha is just another consciousness he isolates from. But that, I mean, to me means that he is unable or struggling to process his own emotions, even if he is really qualified and good at processing other people's emotions. Kind of like how therapists aren't like necessarily great at therapizing themselves, kind of thing.
Again, another metaphor. Yeah, another at least another parallel. What I think might be part of this conversation is something that is labeled capitalist realism, right? So where, and this is Mark Fisher, emotions are no longer about feelings. Emotions are about the product that benefits from those emotions, right? So individuals will react more to the number of likes they have in terms of the actual experience and the feeling, right? Which is real, that happens. And we've seen that result in acute crises in our ERs now, right? There's a Black Mirror episode that focuses strictly on that. I think it's called Nosedive. Right?
Yeah, to speak to the Mark Fisher thing, because I really like that book. Like that, when we're in a society which like operates in a certain way, it's very hard to see if someone's actions like if we're in a society which is devoid of emotional expression, how do you know he is not just responding to the environment, right? And I think that's basically what you were saying, but it's like a very pertinent point here where like you don't get to see the whole society, you really only get to see these little snippets of like how people are interacting with each other, but in the society, and that people truly are not able to see another way of engaging with each other. And I really think it's like in a more pessimistic view what the movie is raising in general of like in a more automated society, in a society where everything is through technology, is that a negative? Like, can we still experience these sort of emotions, or are they genuine? Is this like the same as a genuine connection? It's just like in a different setting. So, I mean, I think that's like very pertinent here.
And I want to bring this back to, again, psychiatry and a clinical role. How different is that than saying when somebody presents to you, and this is something I mentioned this morning, and I'm going to mention it every Friday that we meet, as clinicians, we have to always say that this is normal behavior until proven otherwise. And normal means that it is accepted by an identified culture. So what we might think is abnormal when we take it in proper context, whether we talk about a film that's titled Her or whether we're seeing this in a person sitting right in front of us, this may be normal. This may be something that is absolutely sanctioned by his culture. Okay? Which also, I think, and I agree with you, impacts the ending of this film. On the surface, it looks like it's a happy ending. I have a quote, I just come to realize that we're only here briefly, and while I'm here, I want to allow myself joy, and that's Amy. If this is culture-driven, if this is the norm, what is she in for?
Yeah.
It may not be nearly as positive an ending as we might think. Because then she, and again, we've seen this way back in, like from Twilight Zone episodes, what we would consider to be normal at face value, within the context of a culture, it could result in clinically significant distress for this one character as she's trying to allow herself joy. She might be able to. Right. Other thoughts here?
I think the interesting thing, I'm talking a lot, but I think the interesting thing there is if you're in a society which is set up in a way in which not to make you happy, then to experience joy is inherently like countercultural.
Yeah.
You know, so I don't know. I mean, you really don't get to see enough of the society to make that judgment. But I think there is something there that like that could be a truly radical act in this society.
I agree. The Twilight Zone episode that comes to mind is The Eye of the Beholder. Right. So check it out. I may have already given you too much of a spoiler, but check it out anyway.
I think along that line, Amy is a really interesting person to explore, especially if we're trying to relate it to a culture, like our culture and the culture we understand, because at surface level, she did have all the things to make her happy, like good job, a husband who cared about her, all this stuff, and then she divorces her husband, like leaves the home to pursue happiness with this female AI that was, I think, given to her by her husband or something, or left behind by her husband. And I'm not clear if like the AI precipitated the divorce or the AI was something that she received out of the divorce, but it almost seemed like she left these trappings of what the culture would consider the thing that is supposed to give her fulfillment to then find fulfillment elsewhere in a countercultural sense with the AI.
Mm-hmm. I'm going to see the sequel.
But I think that's the thing too that like, so I mean, like cards on the table, like I'm not really put off by the fact that he falls in love with an OS. Like I don't really, it's fine. Like, like I know for a lot of people that's like the initial hang up is they're like, oh my god, he's in love with a computer. It's like, I don't really care. You know, but I think in that sense, like him pursuing that, and honestly, everyone is kind of non-judgmental, to be honest, which is like refreshing, because it could have totally been a story of like, oh my god, like it's terrible, he's in love with his computer, and like you get a little bit of that with his ex-wife who's like, oh my god, you're in love with your laptop, and like, you know, there's some of that. But like I would say that his story and Amy's story are parallel in that way of like, she's sort of leaving these like traditional trappings of like what we in our modern society consider like the things that make you happy, like marriage and whatever. And then he in the same way is leaving like, what our norm is like, oh, well, you love other people, right? You don't love your computer or an OS. Computer is so simplified, but like an OS, you know? And so in his way, he's also acting counterculturally. He's like, I am pursuing what is making me happy, even though it is like countercultural, right? And that's the thing that's gonna make me happy. So like, that's why their stories are so good together, because and why I think you see them like coalesce at the end. It's sort of like maybe implied that there's something is gonna happen with them, but you're not sure. But like, yeah, that they're both choosing the like countercultural path to happiness that is not laid out.
Is there a chance that Theodore is misinterpreting withdrawal for longing and love? I mean, there's a new condition that the APA is discussing called internet gaming disorder. And people who invest significant amounts of time in internet gaming, when they're not gaming, begin to feel withdrawal, which is allowing this condition to be incorporated into the addiction disorder chapter of the DSM. In the time that he's away from the operating system, does our main character experience exactly what the APA is addressing, albeit through internet gaming?
I mean, don't people experience that with love? Like once you break up with someone, do you not experience withdrawal? Like I don't know. It's hard to say. I mean, because I think people can be addicted to a lot of things, and she says it in the movie that like love is just socially acceptable, insanity and addiction or whatever how you want to say it.
Mm-hmm.
But like yeah, I think once you have something which is important to you or fills some hole in your heart as he describes and it is gone, you know, you can experience withdrawal.
I think also along those lines, like especially because we're talking about like a culture that's similar to ours but not quite ours, like the fact that society is defining what we are deeming pathologic and what we're deeming physiologic. Like it is physiologic to mourn the loss of relationship, but not for longer than like 3 months or 6 months, and then it's like pathologic to then extend farther than that. So now we're putting timelines on grief and what you're allowed to grieve and what that grieving is allowed to look like, which is in essence the nature of psychology, but it is interesting to then transfer that here and say, okay, now in this universe, this is no longer pathologic, this is understood, this is physiologic, and then does that change also how we look at things in our world and like how we discuss, like if you would deem this pathologic from a perspective where a man has fallen in love with his OS, would you then deem, you know, a breakup pathologic in our universe?
And I think over time, isn't that like what psychiatry has done over and over again? Like things which were pathologic are no longer pathologic, and in a world in which like tech and stuff becomes more integrated, that I think will happen again and again as well.
Mm-hmm. The DSM is ever evolving. It's a living document.
I think it's interesting, like as tech evolves, we develop technology that's better and better at taking up our time and our eyeballs. Like the number one like reason for like a lot of social media, whether Facebook or TikTok, like their number one metric that they try to maximize is eyeball on screen time. That is the by far like the biggest metric for them. At some point, if you just spend thousands of developers years and years just maximizing that, you get really good at that. Like TikTok, I think in my view is like scary how astronomically good they are at maximizing eyeball content, especially for ages. Like it's crazy, it's absolutely crazy. Like how efficient they are, how good the algorithm is, how they spend billions of dollars as a startup to get that first past the post to develop this sophisticated algorithm that traps us. It's also like kind of part of the Chinese government, which is a whole nother thing. Like if we're trying to you said talking about how video game addiction is becoming a new thing. It's because video games now are really good at like taking eyeballs. Like they develop loot boxes, which makes you gamble. It's like it's very stimulatory, and like I think social media is really good at doing that. Like at some point, like I think they're kind of like part of the same coin. The idea that like we know what humans are attracted to. We know we've gotten good at like discretifying what factors can make you stay there and watch and keep watching over and over again. And like, I think it is an issue in our society, but like, is it to give tools to the patient, to the person suffering from spending all those hours, or is it like, should the focus also be on like more upstream as well?
Mm-hmm.
I think as clinicians, we're obviously going to put our focus on the patient.
Yeah.
Just interesting.
Yep. Speaking of which, easy segue, and we'll close with this. Let's frame this in terms of a person, we'll name him Theodore, presenting to us with clinically significant distress. So as psychiatrists, that's always going to be that line to be drawn. So at this point, we should feel comfortable enacting a treatment plan, which will of course include psychotherapy. But for the purposes of this exercise, let's say that pharmacotherapy is indicated. I don't want to talk about antidepressants in general because I think the time we have left is unfortunately too short to talk about that large of a subject. I do want to look at the second and third line agents in as much as they're going to appear on your shelf exam. Right? So let's skip over first line therapies and let's look at pharmacotherapy, second line and third line. Second line agents are largely the tricyclic antidepressants. Right? What I need you to know about the tricyclics, again, and this is a nice way to kind of progress through any didactic like this, is that what the intended benefits are. And there's really two answers here. Number one, of course, is the improvement in depressive symptoms. Right? So that one's pretty straightforward. Otherwise, we wouldn't be talking about antidepressants. In clinical practice, and certainly therefore reflected on shelf exams, the second answer is all of those other FDA-approved indications. So please know them. All right. So the examples that come to mind include anafranil, which is not only a TCA, but it's a TCA due to its serotonergic activity that has been FDA approved for the use in the treatment of OCD. Okay. And then imipramine is another one that comes to mind. Again, another TCA. So not only would we expect to see improvement with regard to depressive symptoms, but this particular agent has also gained FDA approval for the treatment of panic disorder. So while you might get a clinical scenario, in fact, that has a TCA as a single best answer due to the treatment of depression, there might be a vignette that is a little less straightforward and is going to require you to understand that anafranil and imipramine have alternate or alternative indications. Right? So know those, OCD and panic disorder. At what cost? Right? This discussion always takes into account side effects. The side effects for the TCAs as a class are very similar to what we would expect from the second generation or atypical antipsychotics. Right? And they can be recalled by the acronym STOMAS, STOMAS. So what do we got? In this case, we're talking about atypicals as well as TCAs. They're really very similar.
Sorry, what was it?
STOMAS.
I think arrhythmia is the biggest concern with TCA.
Yeah. So that I'm going to give that a T for torsades, right? So this can prolong the QT interval. The mechanism of action, I think, for the in prolonging QT for the atypicals is less well understood. We do know that the TCAs are actually type, I think they're 1A antiarrhythmic drugs, right? They operate on sodium-gated channels, and therefore they are potentially proarrhythmic. So they have a quinidine-like effect. So torsades as a result, so arrhythmias, yeah.
They could cause sedation.
Absolutely. So sedation is the S.
Metabolic syndrome?
Yeah. There's metabolic side effects, including the metabolic syndrome. There could be weight gain. Now, the weight gain is via a different mechanism here. Weight gain primarily for the TCA is through an antihistamine effect and therefore increased appetite. And while the weight gain is similar for the atypicals, we do have cases of individuals on these atypical agents that don't gain weight, but they do have diabetes nonetheless as a result of the medication side effects. So it's not as straightforward, right? So there might be cortisol that plays a role here when it comes to the dyslipidemia and diabetes that we see for the atypical antipsychotics. The TCA is relatively more straightforward. If you gain weight, you have an increased risk for developing diabetes. More of a linear relationship there that, unfortunately, for some folks, does not exist. So we've got to be careful. So individuals who don't gain weight on an atypical still require semi-annual fasting blood glucose levels as well as annual lipid panels. That's the M.
Is the O overdose?
That's always a concern, yes. O is orthostatic hypotension. A is anticholinergic side effects. And then S is seizures. They lower the seizure threshold. Right. That is an ultra-quick, overly simplistic primer on the TCAs. The other thing that, and we're not going to do this now, we could certainly do this later in the day if anybody has time, But it's good to go through the individual agents now and find one fun fact that differentiates it from the rest in the class, right? So each do have like this one salient property that tends to come up on board exams, right? Don't have time to get into that. I want to really talk about the third line agent, and that is the MAOI. Right? MAOIs have alternate indications in social anxiety disorder. So know that. So not only indicated for the treatment of depression, but that alternate indication of social anxiety disorder, which is what, by the way? Which might actually feed back on this particular case.
Fear of embarrassment in a public setting that causes dysfunction.
Yeah. All right. So it's the social or performance situation itself that invokes the anxiety, which differentiates it from agoraphobia, which is more of a fear of embarrassment and becomes symptomatic. So you have to, as a psychiatrist, as a clinician, ask what the fear is. Right? If it's the social situation or performance situation itself, we call it social anxiety disorder. Performance subtype is the most common manifestation. And that differentiates from agoraphobia, which is when an individual also avoids, but due to fear of embarrassment, of becoming symptomatic. So often related to panic disorder, but the embarrassment could be related to any scenario. The other thing I want you to know about the MAOIs is that they have drug-to-drug interactions. So you cannot prescribe these medications with any other sympathomimetic, right? Because you can actually initiate a hypertensive emergency or hypertensive crisis. So this is an abrupt rise in blood pressure with related signs and symptoms that identify end organ damage. So that includes the brain, delirium, the heart, acute MI, kidneys, acute renal failure. The sympathomimetic could be another medication. It could be an illicit substance, cocaine. It could be found in food, right? Tyramine-containing foods, over the counter. So all of the above. Similarly, if you prescribe this medication with a serotonergic agent, you can actually initiate or cause a serotonin syndrome. Serotonin syndrome has a triad of acute mental status change, delirium, autonomic instability. So on the surface, it begins to look like the hypertensive emergency. But what differentiates is that third part of the triad, and that is individuals actually have upper motor neuron signs. So they have signs of myoclonus. They have signs of hyperreflexia. And if you want to build this into a tetralogy, GI signs and symptoms. Questions about second or third line agents? All right. When in the world would you choose either as a single best answer? Well, the first thing is that very seldom, very rarely, do you see both the TCA and the MAOI in the same answer set. It's usually one or the other, because what the board wants you to understand is when to deviate from the first line therapy. And usually there are three criteria that your clinical vignette must need in order for you to choose a second or third line agent. Number one is that there's got to be an indication. Right, so first, and that indication 50-50 may be depression or maybe one of those other indications. Number two, there has to be an absence of contraindications. So the individual presenting is usually young and female. Both are protective factors for co-occurring medical conditions. Individuals who are young are healthier than those that are old. Individuals who are of female sex are healthier than those that are of male sex. So young female will usually be the presenting individual in such a vignette in which the second or third line agent is the single best answer. And then finally, the third criteria to look for is that first line agents have had a therapeutic trial and have been unsuccessful, especially when there are two. So the individual has failed 2 SSRI therapies or 2 SSRI trials. Then you should feel free and comfortable picking the TCA or the MAOI. If both are in the vignette, first, I would love for you, getting out of the exam, text me, because that'll be the first time that I've heard that. But if so, then just choose the second line agent over the third line agent.
In that lineup, where would like something like bupropion, mirtazapine, or like vilazepam?
First line agent.
First line.
Yeah, now we'll talk more extensively about how to go about sifting through the evidence to choose the proper first-line agent. That's its own didactic. But when you do that, and you do that twice, both unsuccessful, and there's an indication as well as absence of contraindications, you're good to go with a TCA, you're good to go with an MAOI. Other questions? All right, we'll leave it here. We'll stop and say goodbye to folks on the other side.